Good morning, ma'am. I'm Dr. Darly Polto. How would you like me to call you?
Good morning, Doc. I am Anna.
Okay, Anna. Now, before we start, I would like to ask some questions in your history to better understand your condition.
Good rapport creates a close and harmonious relationship with patient. Explain the purpose of the interview and get the patient's consent.
I assure you that all information gathered here will be within our medical team. Is that okay with you?
Yes, Doc.
Okay, let's start. What's your full name, Anna?
Juana de la Cruz.
Note
Your
the
age?
day and
I'm
time you
23.
assess the
Your
patient.
marital status?
Note the
ma'am?
gender
I
of the
am single.
patient. The patient is alert, comfortable, well-groomed, appropriately dressed, and cheerful. Grooming and personal hygiene may deteriorate in depression, schizophrenia, and dementia. Excessive fastidiousness may be seen with obsessive-compulsive disorder. Speech is fluent and words are clear. Note the slow speech of depression, the accelerated, louder speech of mania. The patient's mood is relaxed with an appropriate affect with his response and not emotionally labile. Check the mood range of patients from sadness and melancholy, contentment, joy, euphoria, and elation.
Do you see things that others might interpret differently?
I don't think so, Doc.
Now, do you see or hear things that I might not be able to see or hear?
No, there's nothing.
Now, do you have any persistent beliefs that might be quite different? For example, do you feel like there's people trying to harm you?
No, none.
Illusions may occur in grief reactions, delirium, acute and post-traumatic stress disorders, and schizophrenia. The patient is awake, alert, and aware of his surroundings. Patient who has a disorder of consciousness, disorientation, amnesia, misperceptions, hallucinations, often vivid delusions. We could use the GCS to assess the patient.
Please subtract 7 from 100 until I tell you to stop.
193, 86, 79, 72.
Okay, stop.
The causes of poor performance in attention includes delirium, dementia, intellectual disability, and performance anxiety.
Now, can you tell me the date today,
20,
the month,
March,
the year,
2021.
the day of
The
the week?
patient's score here is 5/5,
you
which
estimate
means
the
the
time of the
patient
day?
answers the
10
questions
a.m. in the
correctly.
morning.
This orientation is common when memory or attention is impaired, such as in the case of delirium.
Now, I will ask you to remember 3 words, mango, table, and coin. Can you repeat them for me?
Mango, table, and coin.
Recent memory is impaired in dementia and delirium.
Now, keep the 3 words in mind as I will ask you them what they are. When is your birthday?
January 12, 1998.
The last school you attended?
UNP.
Now, at the beginning, I asked you to remember 3 words. Can you tell me what they are?
Mango, table, coin.
On the other hand, remote memory may be impaired in the last stages of dementia.
Can you name me the last 4 presidents of the Philippines?
Benigno Aquino III, Gloria Macapagal Arroyo, Erap Estrada, and Fidel V. Ramos.
Now, can you tell me the name of the present president and the vice president of the Philippines?
Rodrigo Duterte and Leni Robredo.
Now, what do you think of your illness?
I think my illness is not so serious. It may be because of stress or because of heavy workload. And I don't think I need to stop working.
Patients with psychotic disorders often lack insight into their illness.
What will you do after this consultation?
I will have my lunch further and maybe get back to work.
Now, good, and avoid stress and relax. Now, I will ask you something. What should you do if you suddenly wake up and find a fire in the corridor of your room?
I will look for the fire extinguisher, and if I can't, I will seek help or I will scream.
Now, what are your plans for the future?
Continue working or maybe start my own business.
That's good.
Judgment may be poor in delirium, dementia, intellectual disability, and psychotic states.
Now, please draw a clock and have the hands placed at 25 minutes past 12.
The patient was able to draw a clock and the hands were in the correct position, so that is a score of 10. A score of 5 and below implies that the clock drawing test is not intact, which is possibly caused by cognitive and specific executive dysfunction. Overall, the patient is awake, alert, and aware of his surroundings. He is also capable of abstract thinking, exercises good judgment, and has full awareness of his or her illness.
Now, I have here some items. I want you to name them for me.
Ruler, ring, ball pen.
Now, can you repeat the phrase? Eating ice cream on a hot day can be a good way to cool off.
Eating ice cream on a hot day can be a good way to cool off.
Aphasia is a condition that robs you of your ability to communicate.
Can you read this and do what it says?
Raise your right hand.
Can you write in this piece of paper?
In the case of Gertzmann's syndrome, it consists of dysgraphia, dyscalculia, finger agnosia, and right-left disorientation.
2, 4, 1, 5.
Now is that right or left?
Right hand.
Can you please point to your nose?
Here, there is no
Your left
autotopagnosia,
your
or
right
finger
ear,
agnosia, and right-left
raise your right hand.
disorientation.
Can you recognize this person?
Yes, he's Justin Bieber.
Autotopagnosia or asomatognosia is the inability to locate, identify, and orient one's body parts. Prosopagnosia is the inability to recognize the faces of people in photos.
Right.
This one?
Both.
Left side hemispatial inattention indicates that patients have right parietal lesions.
Can you make a fist? Can you show me how to use a toothbrush and a toothpaste to brush your teeth? Now please copy this figure correctly.
Good morning, Anna. Today we'll be doing the motor examination. Is that okay with you?
Assess for the patient's appearance, specifically for both general and limb posture, muscle bulk, and involuntary movement. Look for common abnormalities such as tremor, which is a rhythmic oscillation around the joint, or fasciculations, which is involuntary repetitive muscle contractions.
On general inspection, there is normal muscle bulk, no evidence of fasciculations nor abnormal movements such as tremors. Now, okay, let's proceed to pronator drift. Can you please raise your arms like this, arms facing forward?
This test has a high sensitivity in detecting weakness of the motor neuron lesions at the corticospinal tracts. If pronator drift is present, the patient's head will pronate and her arm will drift downward. It may take several seconds for pronator drift to occur, so be sure to hold this post for at least 15
okay, now,
seconds.
So let's move on to tone. Please give me your arm.
Tone is the amount of residual resistance offered by a muscle when it is moved passively. Assess tone in the upper limb by rotating the wrist and flexing and extending the elbow. Feel for constant stiffness, which indicates rigidity, catching, which indicates spasticity, and decreased tone, which indicates flexidity.
There's no evidence of rigidity or spasticity. Now let's move on to power testing.
When assessing the motor power, use the MRC scale to quantify the findings. Grade 5 is normal strength against full resistance. Grade 4 is reduced strength against resistance. Grade 3 is movement against gravity with resistance removed. Grade 2 is movement only when gravity is removed. Grade 1, flicker of movement. And grade 0 is no movement at all.
Try to put your chin on your chest like this against the resistance of my hand. Go. Okay, now great. Let's do the other way. Try to bring your head up. Okay, good. Raise your arms up like this. Resist. Okay, great. Now do this. Pull in.
When testing power, it is important to isolate the muscle being tested. Use one hand to mobilize the proximal joint and always compare muscle power on both sides.
Resist. Other hand. Okay, turn them over like this. Resist. The other hand. Put your fingers up like this. Keep them strong. Other hand. Great. Turn your hand over. Flex your fingers. Okay. Other hand. Okay. Your hands up like this. Spread them. Keep them strong. Don't let go of the paper. Good. The other hand.
The patient should try to touch the tip of the little finger with the thumb against the tester's
I'm
resistance.
gonna need to look at your abdominal muscles. Is it okay if we lift your dress?
Watch the umbilicus as the abdominal muscles contract. For a normal patient, when the patient attempts to raise the legs or head, the intake muscles will pull the umbilicus to their direction. The patient was able to do the test without pain or weakness. To assess tone in the lower limbs, gently roll the legs back and forth. Next, lift the patient's knee up first slowly, then quickly. Feel for rigidity, spasticity, and flaccidity. Examine also the ankle for clonus.
Lift this leg. Raise it against my hand. Good. The other leg. Now I want you to push down on my hand. Good. The other leg. Now I want you to bend your knee slightly. Push in against my hand. Okay, good. Now push out. Push out. Good. Good. Now relax. Try to push your heel downward. Good. Other leg. Okay. Push your heel downward. Okay, good. Now, try to extend your knee. Try to extend your knee as much as you can. Go. The other leg. Go. Okay. Bring your feet to your nose and hold it as strong as you can. Go. Okay, good. The other leg. Okay. Feet in like this. Resist. Resist. Good. Bring it out. Resist. Okay. Resist. Feet like on a gas pedal. Resist.
Good morning, Anna. I'm Doc Carlo. I will conduct
Cranial
your
nerves examination. Optic group. Cranial nerves
Can I
1,
examine
3,
you?
4, and 6. Inspection. Inspect the head and shape symmetry, hair, scalp, eyebrows, beard. Compare palpebral features of both eyes. Contours and proportions of nose, mouth, chin, and ears for malformation. Look for scars, for example, craniotomy, pupil equality, facial asymmetry, ptosis, proptosis, neurofibromas. Look for exophthalmos, in which there is protrusion of eyeballs, or in ophthalmos, there is a sunken eyeball.
Okay, Anna. We'll start assessing your visual function. Are you wearing glasses?
No po, Doc.
Can you see the clock on the wall?
Yes po, Doc.
Do you have any problem reading newspapers?
None po, Doc.
I want you to close your right eye. Then read the Snellen chart from top to bottom as fast as you can. Start.
Some abnormal findings include myopia or nearsightedness, or hyperopia or farsightedness. There could also be presbyopia, which causes focusing problems for near vision, and it usually found in middle-aged and older adults. The causes of reduced visual acuity, which are not usually corrected by pinhole or lenses,
Okay, try the other
include
side.
corneal lesions, ulceration or edema, cataract, macular degeneration, retinal hemorrhage, visual fields, confrontation test. Ask the patient to look into your eyes while you place your index finger just outside the outer limits of your temporal fields. Move the fingers in turn and then together. Then ask the patient to point to the moving finger. Test her peripheral field as well on each eye separately, asking, "Can you see the whole of my face?"
I want you to close your right eye with your right palm. Keep looking onto my eyes. Tell me if the silver
Move the red-headed
color
pin
is
from the
gradually
temporal
or
periphery
disappears.
through the central
Okay?
field to the nasal periphery, asking the patient, "Tell me when the red pin disappears and reappears."
Now, Anna, we'll testing your color vision. Now, I want you to read the following Ishihara plate and tell me the number.
Okay po, Doc.
Affected in color blindness and optic neuritis, usually loss of red
Okay,
color first.
shine a light in your eyes.
Yes po, Doc.
Assess pupillary reflex in a dimly lit environment.
Okay, I'll be doing the swinging reflex, okay?
Swinging light test. This reveals the relatively afferent pupillary defect. Ocular motility ophthalmoscopy or fundoscopy records the presence or absence of venous pulsations. Note any opacities interrupting the red reflex. The absence of a red reflex suggests an opacity of the lens or cataract, or possibly the vitreous or even an artificial eye. Lens, commonly a detached retina, or in children, a retinoblastoma may obscure this reflex.
Now, Anna, I want you to follow my fingers.
No ptosis or oculomotor lesion, any restriction of eye movement, or nystagmus causing the eyes make repetitive uncontrolled movements. Weakness of one or more of the extraocular muscles impairs movement of the affected eye and restricts its ability to gaze in a particular direction or
Now,
directions.
I want you to bite your teeth.
Difficulty clenching the jaw or moving it to the
I want you
opposite
to bite your
side
teeth.
suggests masseter
Relax.
and lateral pterygoid weakness
Okay,
respectively.
thank you, Anna.
Jaw deviation during opening points to the weakness on the deviating side.
Please wrinkle your forehead for me. Okay, stop. Close your eyes. Don't let me
Note
open it.
flattening of the nasolabial fold and drooping of the lower eyelid, suggesting facial weakness.
Show me your teeth.
Bell's palsy, a peripheral injury to cranial nerve 7, affects
Okay,
both the
about your
upper and
cheeks.
lower face. A central lesion affects mainly the lower
Okay.
face.
Anna, can you repeat the phrase cuckoo?
Cuckoo,
Lala.
lala.
Okay. Can you show me how you sip the water?
Patients with dysphagia will elicit difficulty in swallowing and deficits in coughing. If the palate fails to elevate when the patient says ah, but does not elevate during the gag reflex, the patient might have an upper motor neuron lesion.
Now, Anna, I want you to turn your head to the left. Don't let me turn it, okay? Good. Turn your head to the left. Don't let me turn it. Okay. Now I want you to shrug your shoulders. Okay. Don't let me push them. Okay, good. Then you stick out your tongue. Move your tongue side to side. Can you smell this?
Yes po, Doc.
What is it?
Coffee, Doc.
Loss of smell or
Thank you. Let's
anosmia
test the other
occurs
side.
in sinus conditions,
How about this?
head trauma,
So,
when lesions
55, Doc.
Okay.
66, Doc.
Okay, tell me when you hear the tuning fork, okay?
Okay, Doc.
Can you hear this?
Yes, Doc.
Tell me when it stops.
Stop, Doc.
Can you hear this?
conductive
Doc.
hearing loss occurs due to excess
hear this?
cerumen.
Yes, Doc.
Otosclerosis and
Stop.
otitis media.
Stop, Doc.
Presbycusis is from
Can you
aging,
hear this?
commonly reflecting
Yes, Doc.
sensory neural
Okay,
hearing
po.
loss.
Where is the strongest?
Middle po, Doc.
Okay, thank you, Anna.
Blinking is absent in both eyes in cranial nerve 5 lesion and on the side of the weakness in lesions of cranial nerve 7.
Okay, close your eyes. Do you feel this?
Yes po, Doc.
How about this?
Yes po. Yes po. Yes.
Can you remove your face mask?
Yes po. Yes po. Yes.
Isolated sensory loss occurs in peripheral nerve disorders, including lesions of the trigeminal nerve. CNS patterns from stroke include ipsilateral facial and body sensory loss from contralateral cortical or thalamic lesions, ipsilateral face, but not contralateral body sensory loss in brainstem lesions.
Hello Anna, I'm Dr. Tangapani Chaudhary. I'm here to do your reflex exam. Can I examine you?
Testing for muscle tendon stretch reflex. This is a good way to examine the reflex arc components. When assessing the reflexes, use the deep tendon reflex scale from 0 to 4. For jaw jerk reflex, the components are cranial nerve 5 and masseter muscles. The abnormal response would brisk closure of the jaw. For the biceps reflex, components are the normal response would be the contraction of the biceps muscle, while the abnormal response would indicate a lesion. For the brachialis reflex, the components are the radial nerve, C6 root, and brachioradialis muscle. The normal response would be the visible and palpable contraction of brachioradialis. The triceps reflex components are the radial nerve, C7 and C8 roots, and the triceps muscle. The normal response would be less than the response of the biceps reflex. For the finger flexion reflex, the patient's fingers flex as they gently grasp your fingers. If present on one side, it is a strong evidence that there is a suprasegmental lesion. Knee-jerk reflexes components are femoral nerve, L3 and L4 roots, and quadriceps muscle. Normal response would be positive flicker of visible contraction of the quadriceps and lifting of the foot off the bed. If reflex is absent, there is a lesion in the segmental arc. The ankle reflex components include the normal response would be jerking of the foot towards the patellar surface. The slowed relaxation phase of reflexes in hypothyroidism is often best detected during the ankle reflex. Clonus of the ankle is tested by rapidly flexing the foot into dorsiflexion, inducing a stretch to the gastrocnemius muscle. For corneal reflex, Notice the brisk closure of the eye. Loss occurs in coma and lesions affecting cranial nerve 5 or 7. For pharyngeal reflex, notice the gagging reaction from the patient, while the abnormal response would indicate a lesion. For plantar reflex, all toes should be flexed. Pathologic or abnormal reflex is a Babinski sign. There are currently 13 methods on how to elicit Babinski sign.
Good day, Anna. I'm Dr. Clarice, and I will be performing your sensory exam.
The sensory exam is to assess the symptomatic patient and to test the hypothesis generated by the motor examination.
So for our first exam, I'll touch you with this cotton swab. Can you feel this one? Yes. I'll touch you when your eyes are closed, and every time you feel me touch you, you say yes, okay? Okay. So first, close your eyes. Can you feel this one? Yes. How about this one? Yes. How about this one? Yes. How about this one? Yes. This one? Yes. This one? Yes. How about this one? Yes. This one? Yes.
Hyperanesthesia is increased sensitivity. Anesthesia is absence of touch sensation, and hypoanesthesia is decreased sensitivity.
Same versus this one? Same. So I'll be touching you with a sharp object, okay? Can you feel this one? Yes. I'll touch you while your eyes are closed, and every time you feel the sharp object, you say yes, okay? Okay. So, can you feel this one? Yes. How about this one? Yes. How about this side? Yes. This side? Yes. This one? Yes. How about this one? Yes. One.
Hyperanalgesia refers to increased pain sensitivity. Analgesia refers to absence of pain sensation, and hypoanalgesia refers to decreased sensitivity.
This one? Yes. This one? Yes. Does this feel the same versus this one? Yes. So this is how cold it feels, okay? Can you feel it? Yes. I'll touch you while your eyes are closed, and every time you feel the cold object, you say yes, okay? Okay. Is this cold? Yes. How about this one? Yes. Cold? Yes. How about this one? Yes. Is this cold? Yes. Cold? Yes. How about this one? Is this cold? Yes. Does the intensity change? No. How about this one? Does the intensity change? No. Is this cold? Yes. How about this one? Yes. Cold? Yes. Cold? Yes. Cold? Yes. Cold? Yes. Cold? Yes. How about this one? Yes. Cold? Yes. How about here? Yes. Is this cold? Yes. Cold? Yes. Does this feel the same versus this one? Yes. So first, close your eyes. Do you feel any vibration? Yes. How about this one? No. How about this one? Yes. How about this one? Yes. How about this one? No. How about this one? Yes. Okay, very good. Do you feel any vibration? Yes. How about now? No. Do you feel any vibration? Yes. How about here? Do you feel any vibration? Yes. How about now? No. Feel any vibration? Yes. Okay. So, which direction is this one? Up. How about this one? Down. This one? Up. This one? Down. Okay. How about this one? Up. This one? Down. This one? Up. What direction
Loss
is this
of
one?
position sense is seen in
About
tabes
this one?
dorsalis,
Down.
multiple sclerosis, or vitamin B12 deficiency, from posterior column disease,
What direction
and
is
in
this one?
diabetic neuropathy.
About down. Up.
If touch and position sense are normal, decreased or absent discriminative sensation indicates a lesion in the sensory cortex.
So, I'll be putting an object in your hand, okay? And manipulate it using your fingers. Okay. Please close your eyes and identify the object. So, can you identify this object? Favorably. Okay. How about this one?
Asterognosis is the inability to recognize familiar objects by
Point.
touch or feel, whereas
About
it
this
is
one?
tactile agnosia if only one hand is affected.
T. Okay. So again, I want you to close your eyes and recognize the number that I'll be drawing in your palm, okay? So identify the number. 6, 3, 5.
The
How about this
inability to
shape?
recognize numbers or graphesthesia
Triangle.
indicates
How
a
about this
lesion
one?
in the sensory
Hexagon. How about
cortex.
this one? Square. So again, I want you to close your eyes and identify whether it's 1 point or 2 points, okay? Okay. 1 point, 2 points, okay? So what is this? Is it 1 point? How about this one? 2 points.
Lesions of the sensory
How about this
cortex
one?
increase
1
the
point.
distance
How about
between
this one? 2
two
points.
recognizable points.
1 point. 2 points. Okay.
I want you to put your feet together. Okay. Extend your arm. Close your eyes. Now I'm going to tap you just to see if you can maintain your balance or
A
not.
positive test is the inability to maintain an erect posture or position over 60 seconds with eyes closed.
Okay, Anna, this part of the exam will test your coordination, gait, and balance. We will start with the coordination of your upper extremities. Is that okay with you? Okay. So we will start with fine finger movements. Tap your index finger onto your thumb like this and make quick, regular movements. Start with your right hand. Go.
Look for rate, rhythm, amplitude, and accuracy. Abnormalities from these parameters can indicate different pathologies.
Regular rhythm. Amplitude was full, nice, and precise, and equal on both sides. Now we will move on to test your rapid alternating movements. So your right hand on top of your left hand and go back and forth like this as quickly as you can, but with full movements, and try to hit the same spot every time. Go. Start.
In cerebellar disease, one movement cannot be followed quickly by its opposite, and movements are slow, irregular, and clumsy. This abnormality is called dysdiadochokinesia.
I want you to touch your nose and then touch my finger and then back to your nose and go back and forth like that. Okay? Start with your right hand. Go.
Normally, patients' movements are smooth and accurate, but in cerebellar disease, these movements are clumsy, unsteady, and inappropriately varying in their speed, force, and direction. The finger may initially overshoot its mark, but reaches it fairly well, termed as dysmetria.
Great, so that's normal on both sides. Now we will test your lower extremities. Let's start with toe tapping. I want you to tap your toes. Make as if you're tapping to music. Make your movements as rapidly as you can and big movements. Start with your right foot.
Look for rate, rhythm, amplitude, and accuracy of the toe tap.
And symmetric on both sides. Now let's move on to heel tapping. I want you to lift your whole leg off the floor. Tap your heel on the same spot and again do big movements and do it as quickly as you can, but lift your foot about 10 centimeters off the floor. Start with your right foot.
Again, look for rate, rhythm, amplitude, and accuracy of the heel tap.
The other foot. Okay. That's normal and symmetric on both sides. Move on to the heel to shin test. I want you to put your heel on the bottom of your opposite shin. Slide it up along the shin, up to the knee, and then go back down again and again in a smooth, rapid movement. Okay, start with your right leg.
In cerebellar disease, the heel may overshoot the knee and then oscillate from side to side down the shin.
Okay, now the opposite leg.
Note the smoothness and accuracy of the movements.
So that's normal on both sides.
This is mainly a test of position sense. The human body maintains balance through proprioception, vestibular system, and vision. Two of these systems should be functional to maintain balance. In Romberg's test, the patient closes his or her eyes so vision is excluded. The vestibular system and proprioception should be intact to maintain balance. If the patient cannot maintain balance after closing his or her eyes, this is in conjunction with other neurologic disorders, and the finding may signify problems in proprioception or the vestibular system. Before the patient begins to walk, observe if the patient is using any gait aids such as canes, poles, walker, orthotic shoes, or knee braces. The patient begins to walk, inspect the patient's movement if he or she walks normally. Pay close attention to stance, stride width, stride length, step height, gait speed, arm swing, and 180-degree turns. Tandem gait will exaggerate strain on the postural reflexes, bringing out any truncal ataxia. Note that abnormalities of tandem gait may also be due to poor proprioception, vestibular function, and leg tremors in addition to cerebellar lesions. Having your patient walk on their toes will test their plantar flexion, form the gastrocnemius and soleus muscles supplied by the S1 nerve root.
Okay, now walk back to me on your heels.
Having your patient walk on their heels will test their dorsiflexion from tibialis anterior muscle supplied by the L4 nerve root. Hopping involves the proximal muscles of the legs as well as the distal ones and requires both good position sense and normal cerebral function. Difficulty in doing a shallow knee bend suggests proximal weakness, the extensors of the hip, or the weakness of the quadriceps, the extensor of the knee, or both.
Good day, sir. I'm Dr. Carla. Before we start with the test, I will be asking you for your medical history and a couple more questions to better understand your condition. I assure you that all the information and data gathered today will be kept within our mental team. Okay? Is that okay with you? Yes. Okay. Let's start. What is your full name, sir?
I am LeBron Alfonso. Doc.
LeBron Alfonso. Your age, sir?
I am 35. Doc.
What is your marital status, sir?
I am single. Doc.
Okay. What can you use for, right? Left or right?
Right.
What do you do for a living?
I am a assistant coach in baseball.
Okay. May I know the reason why you're seeking consultation today?
I am having a hard time doing normal work, and writing, getting hold of things.
Okay. Now, can you tell me how long have you experienced these symptoms?
Let's say almost 17 years now.
Okay, what age are you now?
I am 35.
Do you think it came on when you were a teenager or late teenager?
I am not sure now.
Okay, tell me about what you noticed yourself.
I am having frequent pain when I move my hand. Doc.
When you were at college, do you notice any changes or any problems?
I am having a hard time writing right now.
Okay, fine problem, right? So when you were doing your Gait certificate exam, did you notice any difficulty?
Sometimes.
So then when you were college, did you first notice the problem, right?
Maybe no.
Okay, what do you do in summer? Do you have a job?
I do not. I am coaching.
Okay. When did you first notice difficulty with working in the Gait certificate?
Ever since I started.
How long was that?
It's 8 years now.
Okay, so about when you're 8 years from now, you're 27, 26, something like that? Okay, so about when you're 26, what have your difficulty? What was the difficulty in the past?
I am having a hard time grabbing the ball.
How about when can you manage to put on your stickers?
Sometimes I do.
Do you have any history of balls?
None.
Okay. Now, I'll be asking about your past history, the mental history. Have you been hospitalized before?
No.
Any surgery or undergone any invasive procedure?
No.
Have you experienced any head trauma or any accident?
No.
Any diagnosed disease beforehand or for consultation here?
No.
Did you seek any consultation before?
Yes, no.
Okay. When was the last time you had a checkup?
I think it was last 3 years now.
Do you take any medicine or maintenance medicine?
I forgot the name now.
Okay. Any psychiatric illness? Like
None.
Now, do you know any hereditary diseases in your family? Like you have hypertension or like heart disease, or diabetes in your family?
None.
Any history of cancer?
None.
How about genetically transmitted disease?
None.
Can you tell me about your lifestyle? What are your habits in diet? Do you exercise frequently?
I don't exercise frequently.
What food do you eat?
Balance now.
Like, do you smoke?
Sometimes no.
Do you drink?
Yes, no.
Do you have any alternative healthcare practices like yoga, meditation?
Medication no.
Okay. What are the things interest you? What are your coping style?
Baseball.
I'll be asking more questions about your behavior system. Is okay with you?
Yes, no.
Okay. Have you noticed any weight changes?
I do not.
Any weakness?
Yes, no.
Any fatigue?
No.
Okay. Any fever?
No.
Did you notice any changes in your skin like dryness, rashes, bumps,
yes.
sores? What kind of dryness?
Yes.
Okay. Now, do you have any headaches, head injury?
None.
Okay. How about your vision? Do you have your glasses?
Yes, no.
Okay. When was your last eye exam?
Last year, no.
Do you have any pains, excessive hearing, or double of your vision?
Very vision.
Okay. Let's move on to your ears. Do you hear anything or do you have problem with your hearing?
It's not a lot.
Okay. Do you experience frequent colds, nasal stiffness, or disturbed breathing, fever, nosebleed, or sinus troubles? How about your teeth and gums?
I think there's a lot.
What was your last dental exam?
Last year, no.
Do you have sore throat, dry mouth, or frequent sore throat, and hoarseness?
Courses.
Do you have swollen glands or any pains on your neck? Do you have cough? Experience shortness of breath, wheezing, pain, or deep breath?
None.
Do you have any respiratory problem like asthma, bronchitis?
No.
Okay. Any heart troubles like high blood pressure, rheumatoid fever, heart murmurs, or any chest discomfort or pains?
No.
Okay, do you have any swelling in your head?
Just joint pain.
Bro. Okay, any trouble swallowing?
Sometimes not.
Heartburn.
No.
How about your appetite?
I think it's fine now.
Okay, any nausea?
No.
How about your bowel movement?
I'm having problems sometimes.
Okay, what is the color and size of your skin?
Normal na brown.
Okay. Any changes in your bowel habits?
Sometimes
Do you feel it's fast or slow?
slow down.
Okay, do you have experience with eating?
No.
Okay, any rectal bleeding or black tar stool, hemorrhoids, constipation?
No.
How about your abdominal pains, including tenderness and bleeding?
No.
Okay, any jaundice or liver covenant problem?
No.
How about leg cramps or pains?
Pain.
Okay, do you have feel your fingers during cold weather?
Yes.
Okay, any swelling with redness or tenderness?
Sometimes not.
Do you have problems with urination?
Yes.
Can you describe the problem?
I think I frequently hear it.
Okay, do you have any infection in your mouth?
No.
Okay, do you have any notice negative scalper moving force on your intake?
No.
Okay, do you have any cravings discharge from the source of the pains?
No.
Okay, how about your mood? Do you feel depressed right now?
I do not.
Do you have problems in sleeping?
Yes, I do not.
Any changes in your memory?
No.
Do you have feels suicidal ideas or
No.
something else? Have you noticed any changes in your mood, attention, or speech?
Not much.
How about the changes in your orientation and memory retention?
It's normal.
Any dizziness, vertigo, fainting, and bad blackouts?
No.
Any weakness or paralysis, numbness, or loss of thinking, pains, and needles, tremor, or other involuntary movement?
Weakness, tremors, and pain.
Do you have anemias or easy booster bleeding?
No.
Any problem with your thyroid? Do you have heat or cold intolerance?
I do.
There are 4 primary elements to test for Parkinsonism. Bradykinesia is an important tool in the diagnosis of Parkinson's disease, as well as rigidity, tremor, and gait and balance problems. Observation is an important 5th element of the exam. Closely observe the patient for presence of spontaneous movements, eye blink, fidgeting, cross or uncrossing legs, using hands to gesture, or presence of tremor.
Start by tapping your thumb with your index finger as big as you can and as fast as you can. Like this.
In this test, look for any change in the movement. Take note if the movement goes slower and smaller over time. Ask the patient to do movements big and fast in order to see the subtle changes.
Okay, now I want you to close and open your fist as big as you can and as fast as you can. Please.
As you see through the entire movement, there is a slight reduction in the amplitude and a slight reduction in the speed. That's what you are looking for.
Okay, Sir Lebron, I want you to tap your toes on the ground as fast as you can and go. Okay, the other feet.
You can also look for bradykinesia in the lower extremities. The most sensitive maneuver is to do toe tapping.
Tap your feet on the ground. Okay, the other feet. Okay, thank you.
Okay, Lebron, I want you to relax your arms. I'm going to move your arms and wrist, okay? Okay, relax. I'm going to move your wrist, okay? Okay, relax. Then your arm.
Rigidity in Parkinson's disease is not velocity dependent, and it is not directionally dependent. The most sensitive place to look for rigidity is at the wrist. When the patient exhibits resistance when relaxed, an activation maneuver is used to evaluate activated rigidity. In rigidity testing, you're feeling for the resistance of the movement. Sometimes you'll feel a tremor within the rigidity. This is referred to as cogwheel rigidity. That is a tremor superimposed in the rigidity.
Okay, I want you to relax your hand. I want to put your hands like this.
The doctor should take note of any small movement in the thumb or in the fingers or rotational movements throughout the exam.
Okay, thank you. Okay, LeBron, I want you to release your both arms. Extend them. You'll be counting from
Postural tremor doesn't always come out immediately. Sometimes it reemerges when the hands had been out for a few seconds.
Now I want you to touch my finger, then touch your nose, and touch my finger again, okay?
Action or kinetic tremor is tremor during the continuous movement. Parkinson's disease is more common to have rest tremor with less postural or kinetic tremor. Patients with essential tremor classically have more postural and kinetic tremor and less rest tremor.
Okay, LeBron, I want you to stand up with your
This test
arms
is
out like this.
checking if the patient can stand up from the chair without using the strength of his or her arms.
Okay, LeBron,
Observe the patient's
walk,
turns and the step length if there is asymmetry. Look at the heel strike, whether they are picking their toes up or are they shuffling and scuffling their foot and the patient's arm swing. In Parkinson's disease, you might see an asymmetric step, an asymmetric arm swing, or no arm swing at all.
I'm going to
One common misconception is that if the doctor pulls the patient and he takes a step or two to correct their balance, then it is already abnormal. What it actually is that if they can correct their balance in 1 or 2 steps, then it is but normal. But like in our patient, if he can't correct his balance in 1 or 2 quick steps, then he may be at risk of falling. This exam is used to see how the patient is doing, not just for diagnosis but also for follow-up. Changes in medications are done based on the result, as these medications we have only are to help manage the symptoms. They do not really change the course of the disease